my name is Gréta. Currently, I'm a first-year PhD student and I'm working at Heim Translational Pediatric Institute. My supervisor is Ákos Gasparics, my SMS is Mark Hernát Fői, and my statisticians are Daniel Veres and Ádám Zolcsák. My vision is to improve the quality of life and extend the life expectancy of newborns. To achieve that, optimizing the time of cord clamping and the dosage of caffeine among preterms are my missions. Now let me introduce you my two ongoing projects and specific goals to complete my missions. Our first project is about investigating the outcomes of neonatal resuscitation with and without intact cord. According to the guidelines, based on the ICOR recommendations, for those preterm and term infants who do not require resuscitation at birth, delayed cord clamping is or may be reasonable. Delayed cord clamping is associated with significant neonatal benefits, such as improved transitional circulation, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. Most newborns breathe spontaneously after birth, but around 15% require some degree of active resuscitation. The need is inversely related to the gestational age, so for example, for the very preterm neonates, it is approximately 85%. Unfortunately, for these preterm and term infants, we have insufficient evidence on the optimal time of cord clamping. So our aim is to determine whether intact cord provides physiological, neonatal mortality and morbidity benefits for infants requiring resuscitation at birth. So we compared the interventions of starting resuscitation with intact cord with starting the resuscitation after cord clamping. We hypothesized that starting resuscitation with intact cord decreases the incidence of neonatal mortality and morbidity and increases oxygen saturation level at 5 and 10 minutes after birth. We conducted a systematic search on 19th of November with this search key of 2 domains. It resulted around 16,000 hits, and after the selection processes, we had 14 eligible articles. With the reference checking, we found one further eligible one. In the meta-analysis, we decided to include only the RCTs. 4 RCTs had to be excluded because after contacting the authors, they did not provide specific information about the rate of resuscitation in their population. So now let me introduce our results. First, I would like to say some details which are common in the next few forest plots. We examined how starting resuscitation before and after cord clamping affect the neonatal outcomes. In case of dichotomous outcomes, we used risk ratio for effect measure. If the risk ratio is 1, then it means there is no difference between the two groups. If the risk ratio is above 1, then the event is more common in the intact cord resuscitation group. If the risk ratio is below 1, then the event is more common in the cord clamping prior to resuscitation group. In case of continuous outcomes, we use mean difference for the effect measure. It shows us how much difference there is between the averages of the two groups. As I already mentioned, all included studies are RCTs. We did subgroup analysis based on the gestational age and on the type of intervention in the control group, which could be early or delayed cord clamping when it was possible. On this first forest plot, you can see the result for in-hospital mortality. A total of 5 studies were selected, covering around 600 patients. The overall risk ratio is 1.89, so it means that 11% higher risk for in-hospital mortality in the intact cord resuscitation group. In the following figures, I will show the risk for different early complications of the prematurity. The total sample size was around 300 patients in all outcomes. In case of all grades of intraventricular hemorrhage, the overall risk ratio was 1.25, while in case of severe, which means grades 3 and 4, intraventricular hemorrhage, the overall risk ratio is 0.96. These results suggest that, meanwhile, the risk for all grades of IVH is 1.25 times higher in the intact cord resuscitation. Fortunately, regarding the severe IVH, it is slightly lower in that group. In case of necrotizing enterocolitis higher than grade 2, the overall risk ratio is 2.05, which means a 2 times higher risk for necrotizing enterocolitis higher than grade 2 in the intact cord resuscitation group. If we examined only the studies where delayed cord clamping was performed in the control group, we saw that the risk is even higher because the overall risk ratio is 2.89. Regarding the retinopathy of the prematurity requiring treatment, the overall risk ratio is 1.60, so the risk is 1.60 times higher in the intact cord resuscitation group. Unfortunately, the sample sizes and the event numbers were low in these outcomes, so the results are not statistically significant, but may be clinically significant. After the early complications of the prematurity, here you can see the analysis for oxygen saturation level at 5 and 10 minutes after birth. This is a very important parameter because it's crucial to increase the newborn's mean oxygen saturation level after birth to an optimal level. The mean differences suggest that in the intact cord resuscitation group, the mean oxygen saturation level is higher with 6.67% at 5 minutes and with 2.87% at 10 minutes after birth. This result is not statistically, but a clinically significant result. Here I prepared a summary table of our further results. None of them are statistically significant, but I would like to highlight that the results for parameters of the delivery room management, like Apgar score and the temperature at admission to NICU, are not worse in the intact cord resuscitation group. However, in case of later complications, it is not that clear. So after our results, now let me summarize our strengths and limitations. I would like to start with the formal ones. Our strengths that we included only RCTs and examined the broad population, preterms and terms also. We have a high range of outcomes and detailed subgroup analysis. However, we have some serious limitations like the small sample sizes and event numbers, different definitions of the outcomes, and heterogeneous protocol of the intervention. In summary, based on our results, we can say that intact cord resuscitation might improve delivery room oxygenization, but in preterm infants it might increase the incidence of early complications. So in case of preterm intact cord resuscitation, close monitoring of early complications is required. Unfortunately, there is still no clear evidence for optimal cord management during neonatal resuscitation. Therefore, high-quality RCTs with larger sample sizes and standardized protocol of the intervention is needed. Here you can see the status of our manuscript writing. We are planning to send it to internal review next week. In the last couple of minutes, I would like to say some words about our second project as well, which is about comparing the effects of different dosages of caffeine on neonatal mortality and morbidity. Caffeine therapy is widely used among preterm infants as it is effective in reducing apnoea of the prematurity, need for and duration of mechanical ventilation, and decreases the incidence of bronchopulmonary dysplasia. The commonly prescribed dose is 5 mg per kilogram per day caffeine citrate, but unfortunately there is still uncertainty regarding the optimal dose to achieve effectiveness while minimizing potential side effects. In the available research papers, there is a wide range of the used maintenance dosage of caffeine therapy from 3 to 20 mg per kilogram per day. So our aim is to compare the clinical effectiveness and side effects of different maintenance doses of caffeine therapy in preterm infants. So our clinical question is, what is the optimal maintenance dosage of caffeine citrate for extremely and very preterm infants? We hypothesize that the administration of higher dose than the commonly used 5 mg per kilogram per day of caffeine citrate improves survival and decreases morbidity without worsening side effects. The clinical implication is determining the optimal dose of caffeine for preterms, and this way a decrease in neonatal mortality and morbidity. Here you can see a short summary of my previously described project. And I would like to finish my presentation with one of my favorite quotes by Ray Goforth, which is, "There are two types of people who will tell you that you cannot make a difference in this world. those who are afraid to try, and those who are afraid you will succeed. Thank you for your attention.
Isn't it worse or difficult to resuscitate with an intact umbilical cord?
Thank you for your question. For the purpose of performing this intact cord resuscitation, different resuscitation platforms were developed, like LiveStart and Concord birth trolley. And with those we can provide thermal support, breathing support, like continuous positive airway pressure therapy, and monitorization for oxygen saturation and temperature. So I would say no, with those, no.
Did you find any study when they were performing the whole resuscitation process, stabilization process, with the intact cord, the whole procedure?
Yes, we had one study out of the 6 where they performed physiological base cord clamping, which means that they clamped and cut the umbilical cord only when the infant was judged to be stable, which means the infant had regular spontaneous breathing, the heart rate was higher than 100 beats per minute, and the oxygen saturation was higher than 90% with less than 40% supplant oxygen. So in that case, they cut the umbilical cord around 6 minutes of life. So they performed the whole resuscitation with intact cord. But in other cases, no, just that one study.
I would like to ask about the second topic, if there are any adverse effect of caffeine, and if there is any maximal dosage for the infants, and why wasn't the higher dosage used up till now?
Yes, I couldn't say because of the lack of the time, but they conducted this CAP trial, caffeine for apnea of the prematurity trial, because they thought there are serious neurological side effects of the caffeine, but they found that there was an improvement in the rate of survival without neurodevelopmental disability after receiving the caffeine therapy in long-term follow-up. But of course there are other side effects as well, like tachycardia, bloating, feeding intolerance. And for the maximum, as I said, they used in the available research papers from 3 to 20 milligram per kilogram. And they found that these are safe, can be safe.